Welcome to this episode. Today, we'll dig into the multifaceted problem of dry mouth xerostomia and its many layers, from its imaging and radiotherapy-induced causes to prevention strategies and even novel therapies like gene transfer and stem cell treatments. It's a huge topic that crosses diagnostic, clinical, and biological domains.
Right. It's really complex. Let's start with the diagnosis. I was struck by how the literature distinguishes between xerostomia, the subjective feeling, and salivary gland hypofunction, the objective decrease in salivary flow. That seems critical, wouldn't you agree?
Absolutely. In many clinical studies, the subjective symptom xerostomia isn't always correlated with objective measures like unstimulated whole mouth salivary flow rate. For instance, a patient might report a dry mouth even if their flow rate is above 0.1 ml/min, which is classically considered hypofunction. This leads to using tools like the Xerostomia inventory and the shorter SXI, which are essentially sum-mated rating scales designed to capture the patient's experience in a more, let's say, graded way.
And I recall the discussion about clinical scoring systems specifically, the Clinical Oral Dryness Score, CODS, right? It's interesting how they use observable features like mirror sticks to buccal mucosa or frothy saliva. That seems so tangible compared to purely subjective reports.
Exactly. CODS offers a way to objectively grade the physical signs of dryness. It ranges from 0 to 10, with markers like depapillation of the tongue, frothy appearance of saliva, and even the presence of debris due to reduced cleansing. What's fascinating is the inverse correlation it shows with salivary flow and mucosal wetness. So, patients with high CODS really tend to have significantly reduced flow rates that are quantifiable.
And speaking of quantification, what did you think about the imaging modalities discussed? Ultrasound, scilography, and even MRI scilography. They all seem to have pros and cons.
Oh yes, ultrasound is highlighted as the current workhorse in many clinics because it's non-invasive, inexpensive, and gives good images of the superficial lobes of the parotid and submandibular glands. But its drawback is the inability to assess the deep portions of the parotid gland. Then there's scilography, which uses an iodine-based contrast through a cannula from the duct, but that's invasive and requires patient cooperation. MRI scilography, on the other hand, offers a radiation-free option by using the patient's own saliva as contrast after a scilogog challenge.
Right. And if I recall correctly, the consensus criteria for diagnosing Sjögren's syndrome don't yet officially include ultrasound, but more and more evidence is pushing that direction.
Yes, indeed. For Sjögren's, conventional criteria rely on scilography and scintigraphy. But recent studies suggest that ultrasound, with its ability to show that honeycomb pattern, might prove more practical. Different centers use different scoring systems for ultrasound findings, which means we need more standardization. Also, scintigraphy, while unique in being a functional test with 99 TC per technetate, suffers from low resolution.
Sure, traditional 2D radiotherapy delivered an almost uniform dose that often included all the salivary glands. Now, with IMRT, clinicians can shape the radiation dose very precisely so that the high-dose region conforms to the tumor, sparing the parotid gland, and in some studies, even the submandibular glands and the oral mucosa can be spared. This has led to significant improvements. For example, in the Passport trial, patient-reported grade 2 xerostomia was reduced from around 74% with 2DRT to 38% with IMRT at 12 months.
Yes, and the quality of life metrics were significantly better too. But even with IMRT, we still see that a notable proportion, say around 40%, continue to suffer from some degree of xerostomia in the long run. So researchers are exploring further innovations, right?
Exactly. One of those is gene therapy. For instance, there's this approach involving the adenoviral-mediated transfer of the human aquaporin 1 gene into salivary gland ducts. It's ingenious because it can turn normally non-water permeable duct cells into a conduit for water, thereby compensating for lost acinar cells.
Right, and in preclinical models in both rats and mini pigs, that technique provided nearly normal salivary flow rates, but only transiently. In the limited phase iHuman trial, about half the patients showed an objective improvement. Of course, long-term expression is still an issue due to the immune response, so researchers are now looking into more immunologically minor vectors or even alternative methods such as stem cell therapies.
Speaking of stem cells, that section was really interesting. The idea that salivary gland stem progenitor cells, residing perhaps in the ductal regions, might be harvested and then used for autologous transplantation is truly futuristic.
Yes, there's ongoing work to isolate cells from the salivary gland that can form salispheres. Studies have shown that in mice, a few hundred cells expressing markers like CD117 can restore a good proportion of salivary flow after radiation. Human salivary gland stem cells are being studied too, but we haven't yet reached full clinical application. It's still early days, but the concept is promising given that these autologous cells could potentially regenerate the tissue without the risk of immune rejection.
And then there's the whole area of prevention. Radioprotectors, right? Amifostine has been mentioned several times, though its toxicity and cost seem to limit its use.
Exactly. Amifostine has been extensively tested. It accumulates in healthy tissues and can reduce radiation-induced damage to the salivary glands. But, as you said, due to potential side effects and the unclear therapeutic ratio, its use is not widespread. There's also Temple, a free radical scavenger, in preclinical tests, but we're waiting to see if that translates to clinical benefit.
Then there's another practical side of treatment. Non-prescriptive sialogogues, like chewing gum and lozenges. It was fascinating how mastication not only acutely increases saliva flow, but might, over time, help maintain or even improve unstimulated salivary secretion.
Yes, that cyclic relationship is key. The idea is that regular chewing stimulates the mechanoreceptors in the periodontium, boosting saliva production. Although studies are mixed regarding whether a consistent chewing habit increases baseline unstimulated salivary flow over the long term, there is evidence that such stimulation is beneficial, not only for acute relief, but also for oral function overall. And taste plays a role here too. Sour or even fruit-flavored lozenges might have a more robust sialagogue effect than mint because they're more potent gustatory stimulants.
But I also noted the discussion on how one of the problems with artificial salivas is that many of them don't really mimic natural saliva, beyond just being viscous. They lack elasticity, for example, and they might even displace the remaining natural saliva if their surface tension is too low.
Right. Most products use polymers like carboxymethylcellulose or xanthan gum. They do create a viscous solution, but they fail to replicate the mucin-bound pellicle that natural saliva forms. This adhesion or substantivity is critical because it keeps the mucosal surfaces lubricated for long periods. Some preliminary data shows that even low concentrations of artificial saliva can alter the elastic properties of natural saliva, potentially reducing its protective function. So future innovation might come from hydrogels or even bioengineered extracts, such as the intriguing cuckoo spit idea, which mimics the natural mucin properties.
It sounds almost poetic, taking an insect secretion and enhancing it with human proteins by using molecular farming. But the bottom line is that we need artificial salivas that truly supplement and enhance what's already there, not just replace it with something that washes out too quickly.
Exactly. And what's also key, as mentioned later in the chapter, is the role of unstimulated saliva. Most of our mouths are bathed in unstimulated saliva rather than stimulated saliva. Unstimulated saliva provides the continuous moisturizing film essential for protecting the oral mucosa and its reduction is associated with poorer taste perception and even potentially compromised digestion and nutritional intake.
Yes, and they even discussed that a lower unstimulated flow is correlated with reduced mucosal wetness, which has implications not just for comfort, but for things like taste receptor maintenance and even, ultimately, nutrition.
Absolutely. They pointed out that chewing, proper occlusion, and maintaining natural dentition are all interlinked with salivary secretion. For elderly patients especially, severe tooth loss and decreased bite force may further reduce salivation, creating a vicious cycle. So, preserving natural dentition, encouraging chewing, even if only through sugar-free gum, and potentially training the masticatory muscles through targeted exercises could be part of a holistic strategy. It's all interrelated.
It's a beautiful example of how tightly integrated our oral physiology really is. And as advanced radiotherapy techniques like IMRT and even proton therapy become more widespread, hopefully we'll see less collateral damage to the salivary glands.
Right. Even though IMRT has, as we mentioned, improved parotid sparing, there remains a significant minority of patients who still suffer. Some centers are now exploring further sparing the submandibular and even the minor salivary glands, using new techniques and careful treatment planning. In fact, in planning studies comparing advanced photon IMRT with intensity modulated proton therapy, there's evidence suggesting that protons might further lower the dose to these sensitive structures thanks to the distinct Bragg peak of protons. That could be a game changer for reducing late xerostomia.
And yet, despite these promising improvements at the level of radiotherapy delivery, the quest for a long-term solution for those who do end up with radiation-induced damage is still ongoing with gene therapy, stem cell therapy, and other regenerative strategies.
Yes, it's a layered approach. Prevention with better RT planning, plus interventions to stimulate regeneration. Gene therapy with aquaporin-1 is pioneering but faces obstacles like transient expression, and stem cell therapy shows promise, although isolating functional adult salivary gland stem cells and scaling them up under GMP guidelines remains challenging. Still, these innovative approaches give hope for real restoration of gland function in the future.
It's impressive how, even though there are so many complex challenges, ranging from the biological mechanisms of radiation damage to the engineering of artificial saliva, the field is advancing on multiple fronts. Now, I'm curious about how patient preferences come into play. Do patients have a clear favorite among chewing gum, lozenges, or artificial saliva sprays?
That's a great point. Studies show that patient preference can be surprisingly variable. For instance, some reports suggest that many patients tend to favor sugar-free chewing gum, not only because it reliably stimulates saliva, but also because of its convenience and the dual benefit of mechanical and gustatory stimulation. However, some patients, especially those with very limited gland function, may not benefit from gum as much and might prefer an artificial saliva spray. Cost and ease of use also factor in. In one study, only a small commercial volume of artificial saliva was sold compared to the huge population affected by dry mouth, implying that many patients find these products either too expensive or insufficiently effective.
So ultimately, tailoring the treatment to the individual based on their residual gland function and even dentition and occlusal factors seems essential.
Precisely. The holistic approach means not just treating xerostomia as an isolated symptom, but also addressing the overall masticatory function, dental health, and even encouraging lifestyle changes, such as better hydration and chewing exercises. That way, we keep the natural saliva flowing.
And speaking of lifestyle, it's fascinating that regular chewing might actually improve baseline salivary secretion, although the evidence is somewhat inconsistent. It seems that factors like bite force and the number of natural teeth are important.
Yes. Studies show a correlation between bite force, occlusal area, and salivary flow. In elderly populations, a reduced number of natural teeth is associated with lower saliva production, partly because there is simply less stimulation from a reduced occlusal contact surface. So preserving dentition is really important for maintaining masticatory activity that in turn aids residual salivation.
That makes sense. So, to sum up, we have a multi-pronged strategy. Advanced radiotherapy techniques like IMRT and proton therapy for prevention, then interventions such as gene therapy and stem cell therapy for regeneration, and on the symptomatic side, improved artificial saliva formulations and sialogogues, plus behavioral modifications like gum chewing and dietary counseling, and all this underpinned by better diagnostic scales like the CODS and the Xerostomia inventories.
Exactly. It's really about creating a continuum from prevention to symptom management and, hopefully in the future, regeneration. The integration of objective measurements, such as salivary flow and imaging, with subjective assessments using validated scales, not only helps guide treatment, but also spurs development of novel strategies that could restore function rather than merely palliate symptoms.
It's encouraging to see how even though xerostomia affects quality of life so profoundly, there's a robust research pipeline working on it. I especially appreciate how the conversation connects the dots, from imaging to radiotherapy to gene therapy and even lifestyle modifications.
Absolutely. As we continue to push forward, interdisciplinary collaboration will be key. Radiation oncologists, oral medicine specialists, radiologists, stem cell researchers, and even experts in biomaterials must work together to translate these innovations into clinical improvements for patients.
Well, that wraps up our discussion today. It's been a deep but enlightening dive into the many facets of managing dry mouth and radiation-induced salivary dysfunction. Thanks so much for sharing your insights.
Thank you. And thank you to our listeners for joining us on this multidisciplinary exploration of xerostomia. Until next time, take care and keep those salivary glands happy.